So we have today Dr. Prudence Hall. She is the founder of the Hall Center, and she is a gynec surgeon by background. In her early years of practice, she saw a critical need to address the problems of women and men in their midlife. And that's when she started using bioidentical hormones to help them restore their vitality. In today's talk, she'll be talking about how to use the functional medicine approach to address symptoms of midlife health crisis and how to use BHRT in hormone optimization. She will help in her talk how to recognize and treat the hormone decline that happens over in the process of aging. And yes, so Dr. Prudence, a very warm welcome. It's really exciting to have you here to share your insights on this topic. Over to you.
Oh, thank you so much. And hello, my dear colleagues in beloved India. I'm just so happy and privileged to be able to share my great passion for functional medicine and for managing menopause. It really has been I would say, a driving impetus for my practice, which has just expanded and expanded over 40 years. And I'm really so grateful to be able to help teach you something so that you can take your practice into your hands and really do the highest good for your patients. I think that your attendance here reveals your, I would call it forward thinking, and your vision for yourselves as pioneers in this emerging field of functional medicine. And I was so delighted to hear that India has a new functional medicine, I would say, orientation, which is absolutely magnificent. So during this presentation, I'm going to be talking about a couple of cases. I'm going to talk about one woman in menopause and then a man who has low testosterone. I'm also going to be talking about the thyroid gland and how I must manage thyroid problems correctly or else my patients won't get well. So it's not just about saying that menopause is estrogen, progesterone, maybe a little testosterone if you're forward thinking. It's really about looking at all the hormones that might be deficient in menopause. And one of the big hormones that's deficient in menopause is the thyroid hormone. Before we move on to the clinical patients, I just wanted to share with you something that I found helpful to me when there is an opportunity to learn. And that is a concept called Shoshin, which is a Japanese Buddhist learning mindset of being open, eager, and with no preconceptions. I would love us all to go into that state as I start talking about patients, because I think that we'll absorb information better. And it's just fun. It's fun to approach learning in that way. Okay, so let's start with our first patient. Natalia is a 43-year-old female.
Sorry to interrupt, Doctor. Are you able to share your screen?
Pardon?
Can you please share your screen?
Oh, you mean for the PowerPoints?
Yes.
Oh, I'll bring those up each time.
All right.
Okay, so there's not a slide for this, okay?
Okay. All right. Sure. Thanks.
I have a bunch of slides. I have 13 slides. So the first patient is Natalia. She's a real patient. I saw her about a year ago. She's 43 years old and a female who presented complaining of fatigue. And she said the fatigue was bad. It was bad in the morning. It was bad in the afternoon. And she wasn't able to really perform her work. She was quite in a high level of IT and she couldn't take naps. She said, I just am begging to sleep. I can't do it. She worried about forgetting words, and she felt her memory was definitely less accurate. And she was afraid and said that she was really concerned about this because her mother had recently died of Alzheimer's disease. So one of her goals for the meeting was to prevent this. She said, I need to prevent my brain from giving out. And I always ask patients when I start a consult, so what is your goal for our concept? What do we need to do? because I want to meet all of their needs. I don't want them to go away saying, oh, she didn't address that or that. So I have that goal, and I take that goal of theirs very seriously. So with Natalia, we did a bunch of work in terms of her neurodegenerative decline, but mainly what we did was hormones. Now, she also said that her sleep was poor. She awakened multiple times at night, 3-4 times at night. She was feeling more down and sad. And she said, oh, I'll go in the corner and kind of cry. And then I wipe my tears and I go back to work. But she really wasn't feeling herself, which in the past was sunny and positive. Now, Natalia has 3 children. They're 14, 12, and 9. So she's a working mother, little kids. I consider those little kids, and also has a husband. And she said that at times she was so irritated with her kids and her husband that she would explode into anger. And she kind of said, oh, I think, Dr. Hall, it's because I haven't been sleeping. We know that it's much more than that. But that was what she attributed to. She had gained 19 pounds. And she said, look, I just don't feel like myself anymore. And I hear this time and time again. She also said, I just want to go away. I don't want to be in my life anymore. Could I just go to the seashore and just listen to the waves? So these are, she was pretty desperate when she came to see me. Now, her periods were regular each month, but they were lighter. She said that she and her husband had a good relationship and they were very fond of each other and cared about each other, but she was starting to worry because her sex drive was really quite low. And she said, Prudence, and Dr. Hall, a lot of my patients call me Prudence. I think she was calling me Prudence. It's like, I just don't feel like in the mood. I don't feel like I ever want to make love. And she was worried that this could be affecting her relationship. Specifically, she had no hot flashes, but she felt warm at night and cold during the day. She did say she had a lot of dry skin, itching skin, lots of body pain. She said, I feel like I'm 90, I'm only 43. And she just felt worn out. I mean, really worn out. Now, this patient, I was going to ask our gorgeous doctors if they knew what diagnosis Natalia could have, but I can't see anybody, so I'm not sure. I'm not sure if I can ask that question. But I'll tell you, she has multiple diagnoses. And I find that with most of my patients, they don't present with one main symptom. So this is where functional medicine comes in. In functional medicine, we look for the core root causes of symptoms and diseases. And then what we do is we correct those core root causes, and her symptoms go away and diseases go away also. So the first diagnosis that I made with Natalia was that she is in menopause. And did everybody kind of understand that she was in menopause? Because there are things about her that confuse a lot of people. They say, oh, she can't be in menopause because she has her period. Oh, she can't be in menopause because she's so young. Oh, it sounds like, other things are going on. And indeed, other things are going on that I'm going to touch on. But let's look at our first, it's slide number 3. Did that come through for you? Maybe I will just show you slide number 3.
We can't
Okay,
see
I'm
your
share the
slide
screen.
yet.
Yeah, I'm going to share the screen here. Just 1 second. The slides didn't work. Is that right?
They did work now.
They
But
did? Could you
yeah,
play slide number 3? Would that be possible?
I'll do that. Yeah.
Oh, thank you. Thank you very much.
Is this the
Okay.
one?
Yes, that is the one. Now, just 1 second here. Okay, so yeah, that's great. I'm just trying to get I need to minimize this on my screen so I can see my presentation because now it just disappeared. Oh dear. This happened before. Okay, let me just turn this down. Okay, so this patient, Natalia, had a follicle stimulating hormone of 42. Now, the FSH is a pituitary hormone and it regulates the ovaries. So most of our lives, the FSH is 3 to 5. But Natalia here at age 43 had an FSH of 42. So she was clearly in menopause according to that lab value. I like to check hormones at a couple of different times in a woman's menstrual cycle. I'll check it on day 2 of the cycle because that's a great time to assess hormones and fertility. And also that's when the follicle stimulating hormone is the highest. And then I also check hormones on day 21. So these were actually all drawn on day 21. And her estradiol was 39. Now, what should her estradiol be on day 21? Well, it should be 175 to 200. So this was a very low estrogen. So the FSH combined with the low estrogen is diagnostic of menopause. And on top of it, Natalia had many, many symptoms that I'm going to talk about just the classic symptoms of menopause. She also had a low progesterone on day 21. A normal progesterone that indicates ovulation is 3 picograms per ml. So she was 1.75. So she wasn't ovulating, and you don't ovulate in menopause. And her testosterone level was 16. So could we take away that slide now? Would there be a way to get rid of that slide? How about just taking the whole thing away because I can't see my presentation. Oh, there we go. Okay, we're good. We're good again, guys. So we have a patient who's in menopause. And the classic definition in the United States for menopause is really a terrible definition. The definition is having no menstrual period for 1 year. Now, this is not a helpful diagnosis in terms of clinically managing patients because women can suffer all the symptoms of menopause. They can have blood levels and lab levels that indicate menopause, but still be having their period for 2 or even 3 years. And that's what Natalia was doing. She had been to a few other doctors who said, oh, you're having your period. It's nothing. One, she was prescribed antidepressants for her sadness and depression and irritability. She was also prescribed a weight loss program with Ozempic for her 19 pounds of weight gain. And she said, Prudence, I just don't feel better. I mean, I have these medications, but really I'm not feeling better. So my definition of menopause is having classic symptoms, which I'm going to bring up that slide in a moment, having a high FSH greater than 20, and having low estradiol. And then I don't care whether they have a period or not. I mean, sometimes they will, sometimes they won't. So let's put up that slide, which is slide number 4, the classic symptoms of menopause. So I'd like to, let's see, could we put up slide 4?
Yes, yeah.
Oh, thank you so much. It's kind of hard to do slides on Zoom sometimes. So menopause has very, very classic symptoms. Hot flashes and night sweats, well, a lot of people have them, but please don't feel that the patient is not menopausal if she doesn't have those, because enormous stress will cause adrenal problems. Those are your adrenal stress glands that sit on top of your kidneys. And when your adrenal stress glands are very low, women don't have hot flashes and night sweats. So as soon as a woman says, I have no hot flashes and night sweats like this, I say, oh, she's burned out her adrenals, which is always true. The second symptom is exhaustion. It's exhaustion all day long. Women wake up tired. They go to sleep tired. They feel depleted. Interrupted sleep is very, very common, and I spend a lot of time putting people on melatonin and GABA, which is very helpful for sleep, and also correcting their hormones to help them sleep. Women will go to sleep, they'll sleep 2 or 3 hours, and then they're awake 2 more hours, 2 more hours, and then 2 more hours. And a lot of times they just don't go back to sleep, or they'll sleep for a half an hour. So this is a big one. Depression is extremely common. Low estrogen causes depression, and low testosterone that Natalia also has, and I'm going to talk about that, causes depression, and also a lot of irritability and anger. Women are always telling me, oh my God, I'm blowing up, I'm going to lose my job. Weight gain. What amount do we gain in menopause? Well, I see women who gain maybe 10 pounds, and they feel bad by that, but that's not common. It's usually 30 to 50 pounds that women gain in menopause. And it's at a level where it's not just about looking good and feeling good personally, but really it becomes a medical problem at that point. Brain fog, ADA, very common. Low sex drive. I always go into a sexual history with my patients, and I want to be, I would say, careful when I'm talking to people, depending on what their country they're from, because I work with women from countries all over the world. And some women are very reluctant to talk about their sex drive. They'll close the door, they'll whisper to me. But usually, as long as it's not in front of an audience and it's in a secure place and they feel confident in what's happening with them, they'll share about their sex drive. And they have relief in sharing that because they've been scared. I mean, I don't have a sex drive. I don't have orgasms. My vagina hurts. It burns. It's dry. So I think it's really good to touch on it and say, what I say a lot of times is most women in menopause tell me that their sex drive is very low. And it's so common to have vaginal dryness and just not to have orgasms. Is any of that happening to you? So I kind of put it in that way rather than making them use those words. Okay, then there's aging skin, hair loss. There's PMS. When women do have periods, they'll say, Prudence, I have PMS 3 weeks out of 4. And PMS is premenstrual syndrome, and it's irritability, anger, all the symptoms basically that I'm listing here of menopause, because PMS, the cause of PMS is low estrogen. And I'm talking about 20-year-olds, 30-year-olds, 40-year-olds. It just gets worse as we approach menopause, and estrogen levels are very low. Now, one of the things that I learned when I was going through my own menopause, this is now almost 30 years ago, I was getting OCD. I was starting to get very compulsive. I thought that my charts were dirty. I wore gloves to touch my charts. And after a couple of weeks of this, it's like, Prudence, you are nuts. What is going on? So at that time, I was 46. And it was like, I immediately checked my hormones and I realized being obsessive and compulsive about things is a symptom of menopause that I don't think doctors ever talk about. I haven't ever heard anyone else talk about it. And so now I ask my patients, are you acting a little obsessive? How do you feel? And, a lot of them are. And another one symptom that I certainly 40 years ago, when I left my residency in gynecology and obstetrics in 1982, nobody mentioned anything about GI problems. So bloat, GERD, which is, pain in regurgitation, very common, less recognized symptoms in menopause. So if a patient comes to you and says, hey, I feel tired and I have all this bloat and GERD, think menopause, because it's very, very common. Thank you for that slide. Can we take away the slides? And I'll go back to my talk. So Natalia had almost all of these things. She had the weight gain, the brain fog, the fatigue. She didn't have hot flashes, interrupted sleep, and low sex drive. She also was feeling that she wasn't as attractive as she used to be, and that really bothered her. One of the other symptoms that wasn't on my slide, but is very common that I want you to know about in terms of menopause, is isolating oneself. So women tell me, I don't go out with my friends. I really don't want to have social activities, and they're so tired that they just don't have the energy to do that. And just like Natalia said, she said, I just want to go away and be next to the ocean. And that's what a lot of my patients tell me. You know how in heart disease, there's end-stage heart disease? The heart just doesn't pump and people sit on the couch. They can't move really because their heart just won't circulate blood. So I have a definition of end-stage menopause that none of us ever want to let our patients go to, ever. So it's the witch. And she's, in a house up on the hill, and she has hair that's falling out, and she uses a cane because she fell and broke her hip, very common in menopause. She's angry and doesn't want kids around and yells at them. Her house is a mess because she's too tired to clean it. And she's haggard. She has hair growing out of her chin, and she's, angry, and, everybody calls her the witch on the hill. Well, that is a end-stage menopause. And one of the reasons I'm doing this talk, not only because Dr. Turner and asked me, and Dr. Raj so kindly, but because I don't want your patients to ever become witches on the hill. I want them to stay vital and joyful and sensual and happy and a friend to their kids and to their neighbors and to their communities and their husbands especially. Now, some women, when they come to me, have very few symptoms. And I say, do you have any symptoms? Nope. So what are your goals? I want to know if I'm going to have symptoms later. Now, they're deep in menopause. They've been in menopause a few years. Their FSH is 60. So the higher the FSH is, the deeper in menopause they are. But they say, I want to prevent diseases, and I don't want to get sick. And so unfortunately, my OBGYN board insists that we only treat patients in menopause due to symptoms or if they have osteoporosis. Now, when I speak and I talk, I'm talking about all the ways that we're going to prevent chronic diseases from managing menopause. And slide 5 talks about some of those. So we can put up slide 5. But basically what happens in menopause, right here, is that when estrogen is low, so here's estrogen that's low, up goes stress, sugar, inflammation, LDL cholesterol, and then the subparticles of LDL cholesterol, which is the ApoB and the Lp(a). So low estrogen causes high stress, high sugar, high inflammation, high cholesterol, and these terrible particles that are associated with heart disease, ApoB and Lp(a). So these 5 things here are the core root causes of most chronic diseases. So menopause causes most of the core root causes of chronic diseases. So if we can get rid of these causes by raising estradiol, these core root causes, by raising estradiol, then we prevent a tremendous amount of chronic diseases. And it pisses me off that the medical board, the OBGYN board, is so behind in terms of realizing this. Dale Bredesen's work, and I know Dr. Turner, Dale Bredesen, also, it's groundbreaking in terms of how neurodegenerative diseases are prevented by estradiol and replacing all the hormones that are low. So many people have been really talking about this for several decades, probably 3 decades now. So we're going to have to get on and really look at the diseases that we can prevent by giving estradiol to women and correcting their hormones. So that'll be the next slide right under that. If you could just raise those slides. Great. Okay, so what diseases are increased in menopause? And what diseases are we going to prevent in Natalia? Because she's the patient on the block right now. So we have to help her and make sure all of her symptoms go away and that she never develops these diseases. So the big one and the number one cause for death in women in the United States is heart disease. It's heart attacks, hypertension, strokes. And in my practice of more than 40,000 women over 4 decades, I only have 4 women who have had a heart attack. I should have hundreds and hundreds. And all of my patients are menopausal, basically, most of them are. And I have them all on hormone replacement therapy. And I can personally say that it is an incredible reassurance to see how well estradiol protects the heart. I mean, people will come in with very high cholesterol. Boom, on estradiol, it's lowered. They'll come in with high ApoBs. Those are the subparticles. And there are only 2 things that I know of that'll lower that. Number 1 is estrogen. And number 2 is niacin. Lipitor does not lower these small, dense particles. So anyway, all of the heart disease, including heart attacks, hypertension, and strokes. I only have 1 patient who's had a stroke. She was 300 pounds, and thank God she lived, and she got married after she lost 150 pounds. She's very happy. The second thing is all the neurodegenerative diseases, Alzheimer's disease, Parkinson's. I love Dale Bredesen. I know you do too, Dr. Turner. He's just done brilliant work, and he's personally told me, Prudence, I'm so happy you're placing, your patients on estrogen. You're really saving their brains. And I see that every day. Okay, diabetes and insulin resistance, low estrogen, high hemoglobin A1Cs. It's very typical to see that 4-month marker for sugar damage be at 5.8, 5.9, when really it should be 5 or below. So low estrogen, high sugar. This is a big problem in India. It's a huge problem in the United States. Most cancers have their root causes in inflammation and stress and toxicity. So menopause doesn't really help with toxicity, although women feel a lot better. But a lot of the cancers are decreased. Autoimmune diseases, diseases of inflammation, osteoporosis. In the first 3 years, women lose 10 to 20% of our bones. And, it's a big problem. It's not the only problem, which the medical board thinks is the only problem that's helped, but it's a big problem that is. This is the estradiol replacement in menopause is the gold standard, much better than any other solution, along with exercise. So we can let that slide go. So we want to save our patients not only from having their symptoms, but also we want to help them prevent diseases. And this is a big one, disease prevention. So just as a little pearl to remember, a woman's age should never exclude you entertaining menopause as a diagnosis. Women are frequently menopausal in their early 40s, and the average age of menopause is 44 to 48. Now, I diagnose menopause all the time at 40, 41, and Natalia was 43. So we don't want to have a preconception that menopause is a disease of women in their 50s. I mean, the last time I saw a woman in her 50s who was not menopausal was probably 8 months ago. She was Israeli, and somehow Mediterranean people seem to hang on to their hormones a little bit better. But really, it's about 44 to 48. So when I started my work with menopausal patients 4 decades ago, this was not true. 48 to 55 was very, very common. But I do believe that the age has been lowered for menopause because our endocrine glands are delicate and our ovaries are rather delicate, and stress will affect them. All the toxicity we're exposed to, the increased diet, sugar in our diet and processed foods. And I think that those are some of the core reasons why menopause is earlier. So, check hormones even in your young women. I remember back about 38 years, I'd been out of my residency for 2 years, and I learned nothing in menopause, by the way, in my residency about menopause. I mean, really nothing. I came out of my residency program as a surgeon, and patients started presenting to me with menopause, and I would check their FSH. I put them on primer, and I said, see you back in a year. And that's what I was trained to do. And they would come back like in a month and say, you have to help me. And so really that desperation and my desire to be in service to women is really what put me on the journey of really studying this. I mean, taking this on with a passion. And one of the important pieces of my learning curve with hormones was when I started recognizing that younger girls, 15, 16, 18, 20, who were on the birth control pill had symptoms that sounded an awful like my menopausal patients. Those girls would tell me things like, I'm really tired. I don't have a sex drive, which could be good for young girls, but nevertheless, they didn't have one. They would say they had gained weight and they were depressed and that their brains didn't work. So a lot of my patients on the birth control pill were given Adderall for ADHD, and they were given antidepressants. And a lot of times it was Zoloft or one of those antidepressants. And really, when I started measuring, I said, I better measure these young girls. And when I started measuring them, I realized and saw in hundreds of patients that their estradiol levels were extremely low, like menopausal women. And their testosterone was also extremely low. And then when I recommended that they come off the pill, and I say, look, I've done this with hundreds of women, you're going to feel so much better. They would come off the pill, and little by little, they would drop their antidepressants and they would come off of Adderall. Low estrogen, poor brain function, low estrogen, weight gain, low estrogen, depression. So that was really important for me to realize that a young girl at 15, 16, 18 could have abnormal hormones, not because she was ill, but because we prescribed them for her. And I'm kind of ashamed to say that I prescribed thousands of hormone packets to women before I realized this. But anyway, regardless of a woman's hormones, consider checking, of a woman's age, consider checking your hormones. So just briefly, what's a hormone? It's a chemical messenger created in the endocrine glands in our body, and they perform critical functions. For example, they're responsible for beating our heart, for maintaining our blood pressure, for memory, for mood. They create sleep, they create hunger, thirst. Almost all of our functions in the body have some hormonal component to them. So a lot of my patients come in and they say, oh, Prudence, I'm not sure about those hormones. Aren't they dangerous? And it's like, if you lose your hormones, all of them, you will die very rapidly. No, I don't think they're dangerous. I think that you want to have youthful levels of hormones. And that's been my philosophy for years. When women start losing their hormones in their late 30s, early 40s, in perimenopause, and perimenopause is about 5 years before menopause, then we want to measure their levels and replace their hormones back to youthful levels. Now, this is not something that people are even taught now as gynecologists and obstetricians, as OBGYNs. They're told pretty much what I was told 40 years ago. Which is disappointing. But what I do is I like to check all of their labs. And I'm going to get into all the labs that I check on my menopausal patients. And then when they're low, whatever hormone is low, I replace with bioidentical hormones. And bioidentical hormones are exactly the same hormones that my body is making and that all the women in our physicians are also making. And we have to agree that Western medicine does not have the history that Ayurveda has. The wonderful Ayurvedic practitioners, I hope some of you are listening. Our history of Western medicine is 100 years. In 1920, we didn't even have penicillin. I think Daryl, maybe you remember, but I think it's 1924 or something by Dr. Fleming. So we didn't have names for hormones. We had no idea really what was going on in the body. So I think having a little humility when we approach this problem, just to say, look, Western medicine has been around for 100 years and we've made great progress. We've done a great job. But it wasn't really until I started studying functional medicine about 20 years ago that I started to really transform my practice and understand much better how to deal with the core root causes. So one of the labs that I put up with Natalia was a testosterone level of 16. Now, testosterone for women is critical. It's a very, very important hormone. So what it does is it gives women confidence, a sex drive. And I would state that a sex drive is very important. You don't have to use it to make love. You can use it to create beautiful Picassos or plan house renovations or whatever. You can build businesses with that kind of sex drive. People used to say that Clinton had this huge sex drive. Now, I think he used it sometimes for sex, but look at his charisma that came out of his sex drive. It was formidable. And I met him once. He was like, oh, I see what people are talking about, because he used it for diplomacy and to bring about peace agreements with multiple countries. So keep your sex drive. Testosterone builds muscle mass. A good muscle mass is one of the bioparameters of aging. So we have all these markers as to how old people are biologically, and muscle mass is right up there with being important. It causes denser bones, it creates more energy, and it helps women with this thing that I call forward motion. Forward motion in people's lives, in women's lives, is being more goal-oriented, more strategic. It's not kind of going like, oh, we're going to go around in circles 100 times before we come to a decision. It's being decisive, and testosterone does all that. So the fourth hormone that I manage in menopause is progesterone. So estrogen, testosterone, progesterone. So the third hormone, I was talking about FSH, but the third hormone is progesterone. And it is low or absent in menopause, because in menopause, women are not ovulating. And ovulation occurs halfway through the menstrual cycle, around day 12, 13, 14. And when we ovulate, that's when progesterone comes into a woman's cycle. All month long, she has estrogen. The estrogen levels fluctuate. She has very high levels of estrogen at ovulation, about 300 to 500. But most of the cycle, it's around 200 for her estrogen. Progesterone is from days 14 through 28. And progesterone is an important hormone. When women have low progesterone, they're more likely to miscarry, and that's very common. Just like with low thyroid, women will miscarry. Progesterone also increases GABA in the brain. And GABA creates calm, better sleep, and less stress. So progesterone also is a check. It stops estrogen. So estrogen is proliferative, and estrogen is proliferative. It causes more growth in cellular growth. It thickens the endometrial lining, and progesterone decreases estrogen and keeps the endometrial lining very thin. Progesterone also causes something called apoptosis, which is killing cells that might become cancerous. So it's kind of a scavenger looking for cells that need to be eliminated. So progesterone needs to be added to the regimen in menopause. So let's just go over how I treat decreased ovarian hormones. Number one, I replace any low or missing hormones with bioidentical hormones, and I bring those hormones back to youthful levels. I don't use the laboratory reference ranges in terms of knowing what is youthful. I've done hundreds and hundreds and hundreds of thousands of labs, millions actually, probably, I should count. But, I know what youthful levels are, and I'm happy to share youthful levels and let you know what youthful levels are, but they're levels of a woman around 30 to 35. And I bring a woman who's in menopause. I'm not going to balance her hormones to somebody who's 70 or 80. I'm going to balance her hormones to someone who's youthful, who doesn't have diseases and who doesn't have symptoms. So that's about 35. So I have my healthy hormone values to use as guidelines for my menopausal management. I only use bioidentical hormones. And why use Premarin? I mean, that's a terrible drug. It's pregnant horse's urine, and so many spinoffs from Premarin happened. I never use oral estrogens. I always use creams or transdermal or vaginal solutions. So let's treat Natalia's menopause. And then we're going to go on to something else, okay? But could we see slide 7, 8, and 9? I just want to show you how I write the scripts for her condition, so you'll really know. Okay, so what I do is I use a combination to treat my menopausal patients with 2 estrogens. 80% estradiol, which is a potent estrogen that basically runs your body, and then 20% of estriol, that is a hormone that is very high in pregnancy. And I do a 2.5 milligram bias mixture. So that means 80% of that 2.5 milligrams is estrogen and 20% is estriol. And this is how you write the script. You write biased 2.5 milligrams per ml. Okay, so I don't have the ml there. Apply 1 pump to the abdomen here, inner arms, or the inner thighs right here. Twice a day, morning and night, about 12 hours apart. And most of the time, these hormones come in pumps. They also can come in toppy clickers where you turn the base and the hormones come up. But I start with 1 pump in the morning and 1 pump at night. Now let's look at the other hormones. We can go to the next slide. Just scroll down to the next slide. Okay. Also, we can use an estradiol patch. And when I speak, I'm very careful not to be negative about the pharmaceutical industry because they have done some really miraculous things. They just charge too much and they create diseases to make medication for, but this is one of the good ones that they do. It's called the estradiol patch. It is bioidentical. In the United States, insurance covers it. When insurance doesn't cover it, it is very expensive. It can be $300 a month. When insurance does cover it, maybe it's $50, $40 a month. So what you write is estradiol patch, and I start with 0.375. If women are really miserable, I'll start with 0.5 milligram patches, and you apply the patches morning and night. So here's what a typical script looks like. Estradiol patch, 0.0375, apply 1 patch 2 times per week. And I always say, apply the patch Monday morning and change it again Thursday night. Change it Monday morning, Thursday night. That'll divide the 7 days of the week into 3.5 days each. Patches work very well. Sometimes they work better than creams. Usually I start with creams, but I'm really open to what the patient's financial ability is, and if it's going to cover it with insurance. I always take all that into account. The creams are not terribly expensive. I don't know what Dr. Turner's creams are. He creates a fabulous cream, but it's probably around $50 per pump. And he'll maybe chime in with this later, but those pumps will last 2 months sometimes. So maybe it's about $25 a month for the creams. So let's see the last, the next one, because this is testosterone. Okay, so when I write for testosterone, I start with 1.25 milligrams of testosterone. And sometimes if their level is very, very low, like Natalia's, her level was 16. And what do I like? 50, 60, 70. That's a youthful reference range for testosterone. So I actually started her on the 2.5 milligrams per pump. And the SIG is to apply 1 pump to the side of the body, right where there's no hair, in the morning, and 60 grams. So those are the 3 prescriptions that I gave Natalia. She wanted to start with the creams. I gave her testosterone, and then I give progesterone, which is really easy. Usually it's a 100 milligram capsule. I mean, I have 5 different ways I use progesterone, including suppositories and drops and all this other stuff, creams sometimes. But really, it's nice just to start with 100 milligrams of progesterone every night, or you can cycle the progesterone to mimic a woman's menstrual cycle, where she only has progesterone for 2 weeks out of each menstrual cycle, out of each month. And then what you do is you say 1 through 15 of the month, you take 200 milligrams of progesterone, and the rest of the time you don't take progesterone. So that's kind of like a youthful level. It's, if a woman hates her menstrual period, has terrible cramps and bleeds like crazy, I would never cycle her. But some women say, yeah, I like my period, and they have light menstrual periods and no cramps. And really cycling, there was a study of 450 women in Denmark, and they said, well, there's less sugar elevation. So the hemoglobin A1Cs were lower in women who had cycled progesterone. And also there were less strokes. So, I'm asking their family history and I'm looking at their sugars, but I generally, I kind of would say it's 50-50. Okay, we can let that slide go because I need to talk about a really important hormone that you just actually had a fabulous discussion on. And in menopause, it's not just the ovarian hormones that decline. As I mentioned before, when looking into Natalia, she clearly was hypothyroid. I mean, she was losing hair, she had gained weight, she was depressed, and so many of these symptoms overlap. So what I do is I give the thyroid questionnaire that Dr. Turner, I believe you shared with them. And also I have a menopausal questionnaire that I have them just fill out very quickly. And the menopausal symptoms are all the symptoms that I mentioned. And of course, I'm looking at their lab values and I'm really determining if they're in menopause or not. But sometimes when women come in and they don't have their lab values, it's a little embarrassing to say, but I can probably balance them almost as well without having any labs. But I think it's a great idea to start having the major labs with your patients. So I manage thyroid constantly because one of the times that thyroid hormone decreases dramatically is in menopause. So menopausal patients frequently have low thyroid. And of course, younger patients, I check all younger patients for low thyroid too. One specific category of women, I'm always checking to make sure that she doesn't develop hypothyroidism, and that's the postpartum patient. So if your patients have postpartum depression, you definitely want to check their thyroid because the babies take the mother's iodine, and the mother then, after the birth, can't make thyroid 4, which has levothyroxine. I call it thyroid 4 to patients, but levothyroxine, which has 4 molecules of iodine, or liothyronide thyroid 3, which has 3 molecules of iodine. So for my postpartum patients, I give them iodine, I give them selenium. You can get 200 micrograms of selenium by eating 3 Brazil nuts. I do it every day. So it's really fun to get, some of your vitamins and nutrients like that through food rather than shakes and things. And the second reason why women have postpartum depression is their estrogen levels drop from levels of 10, 13,000 down to 5. And I've measured so many women who have had babies and they're feeling depressed, and I immediately give them an estradiol patch and thyroid, and it's just like, I'm fine. I love my baby. Everything's fine. I'm so delighted. I mean, it's really a miracle how when you correct menopausal hormones or low hormones, how quickly patients respond. I mean, they tell their neighbors, they tell all their friends. I mean, this is one way, if you really are interested in this, it's one way to really build your practice, because word of mouth is a powerful way to build your practices, and while doing so much good. Okay, so how many patients' thyroids are low that doctors say they're fine? Now, I think that you have gone over this, but I just want to say that it's 40%. And I consider this to be insane. I mean, how can doctors in the United States miss 40% of women's low thyroid? I mean, what? They're committing them to being overweight and miserable and crying all the time and having foggy brains and, all the symptoms. So what happens here is that in the United States, endocrinologists rely overly on the thyroid stimulating hormone, on the TSH. And in functional medicine, we don't do that, guys. What we do is we look at the free T3, free T4, reverse T3, and thyroid antibodies. And we also do Dr. Turner's wonderful Thyroflex. So we're looking at multiple parameters to see to see how our patients are doing. And if there's a borderline case of thyroid deficiency, I give those patients iodine and selenium. And I also try them on a very low dose of thyroid, 15 milligrams of a T4, T3 preparation. And I always use a T3, T4 preparation. And Dr. Turner, you have a wonderful one. I personally use that with most of my patients. It's from New Zealand. It's very pure. I take it myself. So, but there are also pharmaceutical companies will make some. They're called Armor in the United States and NP Thyroid. And, after I've made the diagnosis of low thyroid by making sure, so what I do is Thyroflex, I look at their TSH, and the TSH, my TSH is between 1 to 1.5. That's what I consider ideal. In the United States, the TSH is 0.4 to 4.5. So endocrinologists will consider 4.5 many times as borderline. I consider them, oh my God, your thyroid is bad. It's really low. So, in Europe, they have lowered the TSH in terms of creating a more ideal range where they're going to capture more patients with low thyroid. And it's under 2.5 in Europe. I think Terry Hertog is doing kind of 1 to 1.5. He's a big influential endocrinologist. So what we do is we want the T3 to be at least 3.2. Dale Bredesen, neurologist, says anything above 3.1 is okay. Anything above 3.2 is okay. Terry Hertog says anything above 3.1. I like it 3.3, 3.4 for the free T3. So if you see a person with a normal TSH, a low T3, low T4, slow reflexes and symptoms, using the symptom questionnaire that I use every day of greater than 8 to 10, that person is hypothyroid. And we just have to be a little brave and say, well, let's try some. Let's see how you feel. And most of the time, they're going to feel so much better. They're just going to thank you. They're going to lose their weight. They're going to have energy. So let's put up the slide on
Dr. Prudence,
physical signs of low thyroid. Slide 10.
We have 5 minutes and there are a couple of questions as well, which we would love you to answer. So do you suggest we go on with the slide, or shall I ask you a few questions that's there in the chat?
I think that we probably know the symptoms of low thyroid. I think we know, hypothyroidism, it was so beautifully described with the person before me and what it does. That basically it's cracked heels, there's a tinge of yellow to the hand sometimes, thinning hair, dry hair, fluid under the eyes, very, very typical, rashes, body pain, slow reflexes. And, those are very easy to pick up. And then fatigue, depression, weight gain, memory loss, poor recall, breaking of fingernails, body pain and aches, constipation. So you're going to hear this over and over again. But when patients have those symptoms and they have low T3, low T4, you absolutely want to correct their thyroid, regardless almost of the TSH, because pituitary glands do age. And a lot of times they're not accurate and they just aren't very functional. So let me just end by saying this. This is really a quick dive into menopause and into hormones. And I'm just going right here. So I would love to offer anybody who's interested another hour for a free session to go into balancing men's hormones, which is very, very easy. Men in around the age of 40, 45 start to lose their testosterone. So this is something, menopause is pretty hard, guys. I'll help you crack that nut, but it's pretty hard. But low testosterone for men is really, really easy to manage. And also, I want to teach you how to do thyroid, adrenal hormone replacement. So that's free. I'll talk to Dr. Raj about this and see if we can plan a time for that. And it's just using a little bit more data and knowledge in the functional medicine field to handle hormone abnormalities. And I just want to say that with all these years of practice, I realized pretty early that it's not just writing a prescription, it's actually loving your patients and giving them that extra consideration and care and compassion. And when you combine a prescription for bioidentical hormones, plus really loving them, that rapidly transforms their life. They feel it, they know you care about them. And so I'm sending all of you love, just so you can transform your practice to really the highest potential and have your dreams come true, just like mine have with this miracle called hormones. Okay, what questions do you have?
So thank you, Dr. Prudence. That was really a lovely sharing of information and how you connected various dots. And, often during menopause, the whole focus is only on hot flashes, but there's so much more that a woman is going through during that time. So thank you for bringing in all that so well and, giving the audience the tools that they can use for the patients. So one of the question here is how safe is it to use the estrogen patches for the replacement?
So estrogen is safe. All those things, the diseases that low estrogen helps to, propagates basically or increases, all of those are decreased when you replace estrogen. So I consider it a very safe hormone. There was a study in 2001 showing that Premarin plus Provera increased breast cancer substantially. And that went like a rocket around the world. And everyone says, oh, menopausal hormones are dangerous because of that pregnant horse's mare urine and I call Provera, which is progesterone, a carcinogen. I consider this, strategy of the patch or the cream to be extremely safe. And I have very, very low incidences of breast cancer. I never tell a patient, oh, you'll never have breast cancer, you'll never have heart disease. But definitely the incidence is very low in my practice with thousands of patients. And studies, agree with that, most studies.
Okay, and how long do you suggest a woman who's in her menopause, how long you would recommend supplementing her with this?
So the medical board says 5 years, and I think that that is actually insane because when is a woman going to get sick? It's going to be in her 60s, 70s, 80s. So if you put a woman on menopause, let's say on hormones, let's say at 48, and you take her off at 53, you're all you're doing is getting rid of some of her symptoms. That's like saying the tree is dying, let's quickly paint the leaves. No, we want real functional medicine addressing the core root causes of diseases. And estrogen, testosterone, and like thyroid hormone also very much, they address these core root causes. So I say, I've personally been on hormones now since 48, 25 years. And I have patients who have been on hormones for 40 years because I sort of started the first year putting people on a little bit of hormones. I was going back and forth to France and they were a little bit ahead of us. So I would say for as long as there are benefits, prevent the diseases that you can. And if a woman wants to come off, I wean her off the hormones. And most of the time she says, oh, Prudence, put me back on them right away. I feel terrible. So it's like, okay.
All right. So thank you so much. There's still a couple of questions. So if you can stay back and probably answer those questions in the chat for like 5-10 minutes, that would be great.
Happy to. Thank you.
Thank you
I
so
love
much.
India, guys. I travel there all the time. So I look forward to meeting you personally and
Absolutely.
creating some fun stuff together. Yay, India.
Thank you so much.
Thank you so much for this wonderful summit. I'm so happy to be here.
Thank you.